proceed. Thank you.
Thank you. This last one is more of like a completion because this is not procedure where you're going to have a permanent long-term solution, but this is a very niche technology, and I wish the trainees and practicing urologists from countries like Pakistan should know about this availability. So this is a temporary prostatic stent from the company known as Rocamed. It is known as Exime, and we have come across some implants or the prostatic stents in the past, like for example Memocath. Even Allium came out with a length of smaller length for prostatic urethra, but none of them were really successful. The reason why they were not successful is all this Allium stent or Memocath stent, they are supposed to be left there continuously for long term, like maybe for years. So as I said, anything if left for years together, exposed to urine continuously. See, in Eurolift, even though the stainless steel tab is there, it opens up and the whole thing get mucosalized. So there is epithelized. So the mucosa will cover it. But in the stents like Memocath or Allium, they are still exposed to urine that causes storage symptoms, encrustation, stone formation, etc. So this Rocamed device of Exime is a kind of a marriage between all the minimally invasive things what we discussed and the temporary implant. Very good for patients who are waiting for TURP or HOLEP, where patient needs a catheter and you want to try this Exime stent temporarily. This also gives you an idea how good is patient's bladder function. So if a patient comes to A&E or emergency department, somebody places a catheter and lists for TURP, we don't know whether the bladder is still functioning, is there any hypocontractile element, etc. If these patients have Rocamed Exime temporary prostatic stent, then we know how good the bladder is functioning, so a patient can go for TURP or whole new enucleation as needed. As I mentioned briefly, after resume, instead of the long urethral catheter, they are trying to place the Exime so that patients won't be having the uncomfortableness of long catheter. Young patients, maybe some neurological problems, not really due to the prostate is the problem, but they need to be on a catheter for some reason. Exime gives a wonderful opportunity because they still have some ability to have erection and ejaculation, and men can have penetrative sex with Exime in place. So it is a very good tool to maintain the quality of life for those unfortunate men. And it's a temporary prostatic stent, quite contrast to the previous three things what we have discussed. So the stent has got two main components. The prostatic part, it's an anti-kinking coiled tube, and there is a bulbar urethral part which is like a flat tube. We have made it flat so that it is more smooth for the prostatic urethra and bulbar urethra area, and these wings are known as anti-migration wings, so it prevents both distal migration and also proximal migration, and sphincter will be functioning, and that gives a good amount of continence. And there is a monofilament tether thread which will come out. And the whole set comes with two dilators, which is 22 and 24 French. So once you dilate the urethra, and then you can use the installation device. So once you place this installation device during the dilatation itself, you know with the help of the graduation at what depth the bladder neck is and what depth the urine is starting draining. So you can pass this implanting device exactly to that measure, and once you release the screw and take out the bugey, the implant will get nicely placed, and the sphincter will also function so that patient will maintain the continence. And this video will be useful. So mainly the animation shows that the patient can be in the supine position, and we need to make sure that we are using the dilator. Even if the patient has no stricture, using this dilator which comes in the package will be quite useful, and makes the surgeon confident that before placing we are sure that the implant is going to work well. So the dilatation is only up to the sphincter. There is no need to dilate the prostatic part of it, and it will also give you an idea about at what height you're getting the bulbar urethra also. So this is the whole device. So again, patient's penis should be held taut, and then as you go inside, you know the length beyond which the holder should be holded, so that the whole thing goes in with the prostatic part of the stent alone going beyond the sphincter, and then release the lower lock so that the inner obturator will be removed. And once the inner obturator is removed, you can see that the implant is placed, and you can remove the outer sheath which is used for the rest of the penile. This thread can be nicely secured. We can cut it to the small level, and removal will be much more straightforward. All you need is you just have to pull by using the thread. Patient will be able to pass urine well. Initially, the patient will struggle a little bit because this place is now occupied by the two struts, but patient will be able to the implant also will slightly move to adjust with the prostatic sphincter, and removal is quite straightforward. All you need is a good grasping forceps, and the whole catheter, old stent will come off. Good equipment for those who don't want to have catheter hanging on for longer time. No need for a leg bag. So if you compare the catheter cost, the installation devices cost, the balloon, syringe, leg bag, and everything, this may be a cost viable one. My main attraction or the advantage is you still maintain the bladder function. So bladder cycling is maintained, bladder is not getting drained continuously, and so in case the future patient goes for a definitive procedure for the prostate, you will have the bladder which is cycled, and the bladder volume is also nicely maintained. That is our main aim. And so it is good as a procedure for patients waiting for surgery, and those who are not fit for surgery, those who are left out for lifelong catheter, this may be a good option, so that it is quite cosmetically acceptable also. And the studies have done on acute retention, chronic retention, and retention prevention. Urodynamic test can be performed, and then it's quite good to evaluate the patient's striated muscle or sphincter function, diagnostic tool in neurogenic conditions, whether the bladder is working or not, and the ejaculation is maintained, and patients can have some erection and penetrative sex also. Again, there are some small studies to support that it is feasible. We have got some material like NICE guidelines which are supporting the use of it. This is just like a modified silicone catheter. It's made up of silicone, but instead of catheter coming out and staying for longer, we are able to make it more cosmetically into the required area alone. And it is now licensed to be kept for 3 months, so that's one advantage. Previously, 1 year back, we are supposed to change it every month. And local anesthesia jelly, calibration of the urethra, the steps are very straightforward. And again, I think this technology has a very selective role. Patients don't want catheter, don't want leg bag, want to have the bladder cycling, those who are waiting for the procedure, and also for the patients who had resumed, where instead of catheter we can keep this Exime to tidy up that initial 1 week period. And the whole set comes in a very compact package, including the dilators. So yeah, again, I don't know how long it will take for these technologies to reach Pakistan, but it's at least nice to know that there are some temporary stents available. We don't have to depend on the age-old Memocath and the older technologies also.
Thank you very much. And I think the beautiful demonstration of some of the newer things which are available in the market, and there is good quality evidence available for most of these things now, including the guideline recommendations. There are a couple of questions that are there, which, so for one question is by Dr. Nazam about the incidence of bladder neck contracture in patients who have resumed.
Again, it's quite rare, and there is no reason why somebody should have a bladder neck contracture. Like I explained, any none of the sources should be applied quite close to the bladder neck. So we need to give at least like 1.5, if not at least 1 centimeter from the bladder neck. That's what the literature says. And the expansion of the convective energy bubble is only to 1 centimeter. So in essence, the heat energy, the convective energy should not reach the bladder neck. You will be distal to the bladder neck. If at all, if there is any problems like bladder neck contracture happens, it's only because inadvertently the surgeon is quite close to the bladder neck during the implantation of the resumes energy in the initial areas. So as long as we are 1 centimeter away from the bladder neck, these things are anatomically or at least physiologically impossible.
There's a question by Professor Nasser Orakzai about how do you make a decision? You're doing both procedures, I mean, Eurolift and Resume, and obviously iTend as well. But how do you make a decision between Eurolift and Resume, in a patient?
Yeah, it's a fantastic question, because this is one thing. If I answer supporting one of the energy, people can call me that I'm quite biased. The easiest thing is we have got information leaflet on Eurolift, Resume, iTend from British Association of Urological Surgeons, and we have got nice guidelines also. Slowly we are trying to incorporate urology nurses into our one-stop male LUTS clinics, so that the nurses will be able to counsel the patient just exactly like how I'm going to explain now. Patient should know exactly what they are signing up of. There is no doubt that evidence-wise, whether Eurolift's BPH6 study, lift study, mid-lift study, and Resume-wise like sham treatment study, randomized study, the studies-wise, no doubt they are quite comparable. The outcome is quite good. In Eurolift, patients should know few things like it's a procedure can be done completely under local anesthesia, while Resume doing fully under local anesthesia is a bit challenging. At least patient needs a touch of sedation, if not a quick laryngeal mask anesthesia, because when you inject the steam, it goes for 9 seconds. The last 3-4 seconds patient will feel the bulge. So patient should be suitable for some short very quick anesthesia, while Eurolift is suitable for patients who are completely unfit for any form of anesthesia or sedation. And then in Eurolift, patients should get convinced that they are going to have the implant for rest of their life. It's not a big thing, but for some men who are a bit body conscious, they may find it's bit no. In Resume, they should understand that it's a type of a heat energy, and they should understand the consequences. Post-operative, especially the immediate post-operative wise, Eurolift is a very smooth breeze. There is no major problems. Patient can walk home or drive home, and minimal hematuria or dysuria is quite manageable. There is no need for any specific regimens. But Resume, they need a catheter. That sometime may be a big downside for Resume, so they should accept for a catheter at least for 3 to 5 days. By any chance, if the catheter falls off in a day or two, and if patient goes for retention, it is impossible to keep the catheter when patient is awake. Patient needs to be anesthetized, and we need to place the catheter appropriately. So Resume patients should have a good catheter for 3 to 5 days. So those who already got a catheter, they may say yes to Resume. Those who never had a catheter, they may be more leaning towards Eurolift, so that they don't have to have the catheter either before or after the surgeries. So, but evidence-wise, long-term outcome-wise, both almost score equally. And also it's individual. So if you are trained towards one of the technology, and if you are good in one of the technology, there is nothing wrong in leaning towards that also. So if you have like a multi-consultant, department practice, it's always nice to have one consultant doing Resume and getting proficient in it, and one consultant doing Eurolift, so that we can give quality service to men on both the technologies.
Thank you very much. One last question. I'm sorry, we have exceeded our time. Mr. Ahmed Junaid is asking about retrograde ejaculation with Exime in place.
Yeah. Regarding retrograde ejaculation, the whole anatomy and concepts are changing, especially in 2022 now. So previously, if you say this is the bladder, as long as the bladder neck is opened up, patient will get retrograde ejaculation, either by TURP or bladder neck. That was the concept. But now the concept is changed. The ejaculation is predominantly due to preservation of Veru, preservation of the ejaculatory duct, and preservation of tissue around the viru. So any energy source, whether it's urolift or resume or iTind, as long as they are not working around the viru, the ejaculation will be maintained. Regarding the exime, again it will short stop of the sphincter, and so the ejaculation will be still maintained. It won't be brilliant, and maybe during the ejaculatory episode patient may feel that the catheter is giving a kind of a pressure during the ejaculation period, but erection and ejaculation is possible. Penetrative sex is possible to certain extent, so those kind of quality measures are definitely maintained with this exime temporary stent.
Thank you very much. And again, I apologize for extending beyond our time of 1 hour.
No
I
worries,
think
no worries.
people were really excited by all the technologies that you've talked about this evening. And I think they must have got a very fair idea about. Hopefully, we'll have you next year sometime in our annual conference.
Sure.
You may be able to run a workshop and show them in how to do these things. So thank you again, and a very good weekend and a very good evening to you and to the rest of our group. So hopefully see you again soon.
Thank you,
Take
Professor
care.
Akhtar. Thank you for the opportunity. Thank you for your team, including Sharaf and others. And it's my pleasure to talk on this technology. I'm very sure next year, if you're calling me for the same type of webinar, there will be 2 more extra technologies which we may be able to discuss. We are running a workshop covering all these technologies quite regularly in our British Association of Urological Surgeons annual meeting happening every June, and I will take this opportunity to invite anybody attending the meeting to join us in Birmingham. And we are able to do this workshop even in the Society of International Urology, recently happened in Montreal, and next year it will be in Istanbul. Once you attend these workshops, you will get a hands-on simulator-based training on all the technologies what we discussed. That will give you a much more clarity on the mechanism of this technology. I'm very sure if you are able to invite me for the next annual conference, we will try to mobilize the simulators and do a good workshop so that the trainees and delegates are getting a hands-on experience. I'll be looking forward for it.
Looking forward to that. And thank you very much and take care.
Thank you
Good
very much.
evening.
Have a nice weekend, everyone.
You too.